Hello everyone, this is from Everest Surgeon. So today we are going to discuss about the thromboelastography. So basically there is a lethal triad in surgery, that is acidosis, hypothermia, and one of the triad is also your coagulopathy. So coagulopathy in shock or trauma, it is because of your either because of due to consumption coagulopathy, or because of it is a dilutional coagulopathy due to rapid infusion of massive crystalloid fluids, and either because of any underlying inheritable factors such as genetic causes such as hemophilia and any coagulation disorders. So basically whenever any patient is coming with the coagulopathy, we are doing the basically traditional coagulation test such as prothrombin type, activated partial thromboplastin time, and international normalized ratio, that is our INR. But these tests are having limitation because these tests gives only static or snapshot of the report, and these tests do not assess the dynamicity of the coagulation cascade. So these tests are basically performed at normal pH and normal temperature, but most of our patients in shock, they'll be having acidosis and they'll be having hypothermia, and these tests are performed on the plasma, and these does not indicate the what is happening in the whole blood, and these function do not assess the platelet function and what is the strength of clot and whether fibrinolysis is happening adequately or not. So to overcome this all the drawbacks of the tests, we are having the thromboelastography. So before that, coming to our normal coagulation cascade. So initially whenever there is any injury, endothelial injury, so there is a primary hemostasis, that is due to vasoconstriction because of exposure of our subendothelial collagen, that is type 4 collagen at the basement membrane. So whenever there is a subendothelial collagen get exposed, there leads to adhesions of the platelet and also activation of 1 mm factor, so that further platelet activation and happens, and by release of ADP thromboxane A2 leads to platelet aggregation and formation of temporary platelet plug. And the second stage is secondary hemostasis, which is the coagulation cascade. So basically in coagulation cascade there are two pathways. One is our innate pathway and another is our extrinsic pathway. So innate pathway is mediated by factor 12, factor 9, uh, 6 and factor 8. It is measured by our APTT, and extrinsic pathway is measured by predominantly our factor 7, which is triggered by any kind of tissue injury, which is measured by our PT-INR. And both intrinsic and extrinsic pathway will terminate on the common pathway, which is mediated by factor 10, factor 5 and factor 2, that is our prothrombin, and later it is the fibrinogen, that is factor 1, and fibrinogen is stabilized by our factor 13 and calcium is required. So this is how our coagulation cascade will leads to formation of stable fibrinogen plug. So once the final stabilization happens, so as I told, it is cross-linked by factor 13 and calcium, so stable clot is formed. So there should not be excess of clot formation, so hence it undergoes fibrinolysis by enzyme plasminogen and it is mediated by plasmin. So this is the classical path, this is the classical coagulation cascade, but according to modern view there is no intrinsic or extrinsic pathway. Clinically we think in three steps, that is initiation because of tissue factor, amplification because of platelets and our coagulation factors, and propagation because of thrombus formation and fibrin formation. So whenever there is any kind of injury or any kind of shock, there is activation of coagulation to arrest the bleeding. So in initial stage is hypocoagulable phase, followed by hypercoagulable phase, and at the end there is a fibrinolytic phase. So what is the use of our viscoelastic tests such as thromboelastography or rotational thromboelastography? So basically both the test is works on the principle of assessing the clot formation, clot strength and breakdown in whole body. That is, it is a dynamic procedure, not as our previous tests which are giving us only static results. So coming to our thromboelastography picture, so it is having coagulation pathway and it is simultaneously showing fibrinolysis pathway on our right side. So it is the first is our R, that is a reaction time that is suggestive of our initial clot formation. And next there is a K. So K suggestive of achievement of certain clot firmness. And there is a angle that is called as alpha angle. It suggests of how is the rate of clot is forming. And next one is our MA. MA suggestive of maximum amplitude or maximum strength of the clot. And LY30 and another is the LY60. So what is the percentage of lysis of the clot at 30 minutes or at the 60 minute? So that is suggestive of fibrinolysis. So it is showing both coagulation and fibrinolysis. So coming to our normal R time, that is 3 to 9 minutes, it indicates clot formation is happening in the patient. So if there is any increase in R time, so there is a delayed clot initiation. It is because of factors deficiency. So will give correction by fresh frozen plasma, which contains all the coagulation factors, and prothrombin complex concentrate. It contains factor 2, 7, 9 and 10. So prothrombin complex concentrate will be using predominantly to reverse the warfarin immediately if patient is on anticoagulant such as warfarin. So prothrombin complex is concentrate use. So next is our K time. K time is from the end of R until the clot reaches the 20 milli-mm. So it indicates the speed of clot formation. So normal value of K is up to 0 to 3 minutes. Increased K time suggests of deficiency of clotting factor. So we'll correct it by fresh frozen plasma or prothrombin complex concentrate. So coming to our angle, that is alpha angle. So alpha angle is shows our rate of clot formation. So if there is a decreased fibrin formation, so that leads to our decrease in alpha angle. So normal alpha angle value is up to 54 to 88 degree. So if there is any decrease in the alpha angle, so we'll correct it by cryoprecipitate, because cryoprecipitate or fibrinogen concentrate, it predominantly contains our fibrin. So we'll correct it by cryoprecipitate or fibrinogen concentrate. Next is coming to our maximum amplitude. So maximum amplitude shows our clot strength. So clot strength is basically because of our platelets. So primary clot strength is basically depends on platelet function or also fibrinogen. So normal value of maximum amplitude is up to 51 to 78 mm. So if there is any decrease in the maximum amplitude, we'll correct it by giving the platelet transfusion plus or minus fibrinogen concentrate. So next is coming to our LY30, that is lysis of the clot at the 30%. So how much time it will take? So normal value is up to 0 to 9 minutes. So if there is any increase in the LY30, if it is showing clot is undergoing hyperfibrinolysis, so we'll correct it by giving tranexamic acid, that is antifibrinolytic agent. So ideally we have to give within 3 hours in trauma. So this is the graph showing our normal value. So R suggestive clot initiation, alpha angle and K time is based it's showing rate of clot formation, maximum amplitude is showing our clot strength, and there is a fibrinolysis at the 30 minutes and at the 60 minutes. So basically if there is any increase in R time, it is showing hypocoagulation because of factor deficiency, or decrease in R time, it is showing hypercoagulable state. So alpha angle reflects the rate of fibrin formation and cross linking. So normal value is 53 to 72 degrees Celsius. So based on different parameters, we can assess the patient's condition and we can simultaneously treat it. So basically this is the chart showing what are the parameters to be seen and what are the treatments required based on R time, alpha angle, maximum amplitude, lysis 30 or LY60. So this is not like static phase, it is showing all the dynamicity of your how the coagulation and how the fibrinolysis is happening on this patient. So based on this we are going to specifically treat the patient. So this is our showing our normal thromboelastography. Suppose if patient is taking any anticoagulants or patient is having any coagulation disorder, so there are specific factor deficiency. So if there are any factor deficiency, there is delay in the clot initiation and also on the clot formation. So our R time and our K time is prolonged, and if the clot is not formed properly, so our maximum amplitude and alpha angle is decreased. So our thromboelastography will be like this. This is showing in the second picture. So coming to third one, if patient is taking any antiplatelet agents, okay, or in patient is having thrombocytopenia and sepsis, so our R time or K is be normal, but our K time will be prolonged, because second stage of clot formation is because of clot stabilization because of platelet, and also there is a decrease in the maximum amplitude. Coming to our fourth one, if the patient is having hyperfibrinolytic stage because of any tissue plasminogen activators, okay, so that the patient will be having normal R time, but maximum amplitude continuously decreases and LY30 will be achieved very fast. So our thromboelastography will be in pointed sickle shape. So LY30 will be achieved within 7.5%. So next one is our hypercoagulation state. Okay, so in hypercoagulation state there is a R and K time is decreased because clot will form like rapidly, and also maximum amplitude and alpha angle is increased. So this is basically seen in the DIC stage 1. So our hypercoagulated stage is seen in the DIC stage 1, and next DIC stage 2 is the hypocoagulated state. In that there is a increase in R time and increase in the K time, and simultaneously patient will be having decrease in the maximum amplitude and alpha angle is also decreased. So this is the hypocoagulated state which is seen in the DIC stage 2. So based on how our thromboelastography graph is showing, we can predict the disease and also simultaneously we can treat the patient. So this is the basics of thromboelastography, and all the parameters are covered from the Sabiston standard book and the references point. Thank you. Keep in the touch.